So, good afternoon. Welcome to the presentation on sustainable quality improvement in a lung cancer MDT. And I've put Quan on here because he's loaned me a couple of his slides. So I'll start off with what sustainability is in the context of an MDT quality service improvement, then a very brief history about the PMC, which is their Pulmonary Malignancy Conference. That's what it's generally known as, even though it's an lung cancer MDT. The influence of Cancer Australia's National Lung Cancer Demonstration Project and the optimal lung cancer pathways, and what can be done to progress and sustain quality improvement of an MDT, including some barriers to sustainability. I developed this graphic based on the 3 pillars of sustainability associated with the environment, which is usually the most commonly used sustainability term, and that's social, economy and environmental. But for MDTs, quality improvement should support rather than burden to clinicians to deliver best practice care. It should be cost effective and feasible, making efficient use of current resources, and be in line with one or more of the strategic directions of the health service organisation, just so that you can strengthen some buy-in. Now, a little about the PMC itself. The PMC first started in 1981. It was then known as the Combined Lung Cancer Consultative Clinic Meeting, and it continues today, 36 years on, at the same time every week. These are the disciplines represented in the PMC, and these members are mostly in attendance every week, bar their holidays, or a public holiday. Doesn't happen very often on a Tuesday. From years 2009 to May 2017, a total of 2,213 patients with newly diagnosed lung cancer have been presented at the PMC. And from years 2013 to 16, 25% of them were regional or rural remote areas, 84% had one or more comorbidities, 49% presented at an advanced stage, and 95% of patients received a confirmed diagnosis of lung cancer. And the most common lung cancer presented over that time was non-small cell. So you can see we've been collecting data for a long time. Cancer Australia's National Lung Cancer Demonstration Project commenced in 2014, and the Prince Charles Hospital was one of 4 sites in Australia to participate. The project helped the PMC identify service gaps and put in motion quality improvement based on the 5 principles of lung cancer management, best practice management. And these are patient-centred care, timely access, multidisciplinary care, coordination, communication, continuity of care, and finally data-driven improvements in lung cancer care. In addition to best practice principles, the optimal care pathways for people with cancer have been endorsed by Cancer Australia and Cancer Council Australia for implementation nationally. The optimal care pathways had their origins in the Victorian Department of Health's cancer frameworks, and experts worked together to develop OCPs for nearly every tumour stream from those frameworks, and each state is now tasked with their implementation. The intent of the pathways is to provide an education tool. They can be an audit tool for gap analysis, and they are a mandate for service improvement. OCPs are a standard to aspire to. They're not clinical guidelines. The pathway aligns with key service improvement priorities, such as the 5 principles of lung cancer care, and they are intended to engage clinicians and raise GP awareness. They're also consumer versions to assist patients. So the lung cancer optimal care pathway follows the steps outlined on the slide and also suggests the following timeframes, and I think they're similar across all tumour streams. Results of investigations by the GP should be provided to the patient within 1 week. The patient should be referred to a specialist and receive an appointment within 2 weeks. Once diagnosed, the patient should be presented to lung cancer MDT or whatever tumour stream before beginning treatment, and the time from initial referral to initial treatment should be no more than 6 weeks. So now it's time for a public service announcement brought to you by Quan Fong. Implementing the optimal lung cancer pathway will be a large undertaking with no new resources. So Professor Quan Fong has suggested a Lung Cancer Alliance to provide an avenue for service providers to support each other and share ideas across states and jurisdictions on implementation within their health service. So if you would like to become a member or receive updates on the Alliance activities, please email Quan Fong or me. And now back to our presentation. So quality service improvement starts with understanding your current service, how that operates. For example, what are your patient flows? How are your current referrals managed for patients with suspected cancer? Try to engage the MDT members and identify those with leadership qualities to help with buy-in. And there's no carrots and there's no sticks here. It's all about personality and smiles. Consider if your communication processes, documentation and data collection are up to speed. It's also important that GPs are supported in referring their patients to the correct service in the appropriate time period and with the appropriate workup. The Cancer Australia has developed GP referral guidelines for patients with suspected cancer. However, they are general and some services have more specific requirements that need to be communicated to the GP, so there's no unwarranted delay. So at the Prince Charles Department of Thoracic Medicine is a database of referrals received, and referrals are also managed by a lung lesion diagnostic specialist nurse who liaises with referring doctors, coordinates patient investigations and appointments. It is also at this point that the nurse, in collaboration with the thoracic physician, assesses if the patient can be managed closer to home or if the patient has any psychosocial needs. Although the service aims to have all patients seen within 7 days of the referral and at 14 days maximum, this doesn't always work out because of factors I'll discuss a little further along. To further aid GPs and other referring specialist or hospital departments, the PMC and the Royal Brisbane Hospital Lung Cancer Multidisciplinary Team published their secondary lung cancer assessment and diagnostic pathway on the local map of medicine, which is now defunct. Problem with sustainability. Metro North have since moved away from Map of Medicine to Health Pathways, but we're hoping this pathway will be transitioned across. Then we'll start working on a GP one for the PHN for the primary health networks. So the importance of data cannot be underestimated. Not only can data identify gaps in service, but it can inform funding requirements. It is also useful to ensure quality clinical care and contributes to research and education. So, Queensland Oncology Online is used by many MDTs in Queensland to refer patients to their meetings. Doctors are required to enter the patient clinical data, investigations and results and the reason for referral. A lot of systems already feed in, like pathology, radiology, treatments, chemotherapy, radiation, surgery. An agenda can be generated and a presentation view can be projected at a meeting and real-time data entered. The information is housed in Queensland Oncology, from Queensland Oncology Online, specific to an MDT, is available on Oncology Analysis System. and that's only accessible to the members of the MDT. However, you can access Queensland-wide statistics from it. So data in this cube can be used to monitor and audit the service and is also useful for research and education, and it is used a lot. We do use it a lot in research. So in addition to COOL, the PMC uses a staging database during the meeting itself. A thoracic physician or registrar will enter real-time data to develop a recommended treatment plan. At the end of each patient discussion, the chair ensures everyone agrees prior to moving on to the next patient, and the red circle just shows you how we consider the clinical trial, who's going to be in charge of doing the referrals, and the intent and the sequence of treatment. There is also a real-time TNM staging database that is also entered. The staging is also entered at the time of the meeting, and doctors can all check and agree on its accuracy, and that's also been very useful for education purposes. And we're using the 8th edition TNM staging at the moment, where I think we're a little ahead there. I think one wanted to use it to see how it works out. And following the meeting, a summary is generated and verified by the chairperson, and the summary is filed into the patient chart on the same day. That does not go to GPs because of some, I think most of the clinicians just prefer a standard letter, and just in case the patient does not receive that treatment that was decided or recommended at the meeting. So how did the PMC get super efficient? Well, by being a participant in the Lung Cancer Demonstration Project and through leadership of MDT members and with support of organisations such as Cancer Australia, Queensland Cancer Control Analysis Team and Central Integrated Regional Cancer Service that all provide and encourage best practice cancer care. In 2015, the PMC Strategic Planning Meeting provided an opportunity for members to find solutions to identified gaps in service. The Strategic Planning Meeting wasn't the first for the PMC, but it was the first using 5 principles of best practice lung cancer care to guide its theme. Prior to the meeting, a survey was sent to all the core members of the PMC. And the top issues to arise from responses were leadership and professionalism within the team, and processes of list management, time and even food got a mention. Of 66 responses, 68% believed the PMC processes, multidisciplinary care and membership were strengths, and 21% believed that PMC displayed collegiality and other positive behaviours, and 11% mentioned other strengths such as the availability of food. 55% of 65 respondents thought service improvements were needed. 30% felt individual opinions should be more respected as it is a learning environment. And 15% thought that data collection could still improve. So at the meeting, participants were seated in groups, service gaps were discussed, and then each group presented their findings to the wider audience. And there we have a group very studiously coming up with some solutions to some identified gaps. And then we put all their solutions on a board. I think you've probably all been involved in something like this before. And then we did the democratic process of showing hands. After that, everything was documented and put up with what the action items were and how we were going to go and who was going to do it. And again, by a show of hands. So in summary, the PMC used the following method to implement and sustain the improvements based on our learnings from the Lung Cancer Demonstration Project. So you need to do an assessment of your overall service. Then some clinical audits to provide evidence of need. Have a look at yourselves. Well thought out communication processes. There are lots of tools available on the internet. Ontario Cancer Centre have some excellent resources. We did announcements at PMC, emails, PMC slideshows, newsletters, and then we gave all members in the opportunity to participate in decisions regarding service improvements, including participation in strategic planning, and working groups were huge. So nobody wanted to do the work within the MDT. It was just, they're just too busy. So we formed some working groups, which I'll talk about just very soon. So there was one, was the psychosocial, so looking at patient psychosocial needs. So everybody was invited to become a member of that. And the clinical ones was on clinical matters, multidisciplinary care, education, data integrity and quality. And we have regular meetings and we look at a subject or an issue that's come up and discuss and come up with a solution, and they're used as a conduit to the wider PMC, and usually somebody will report back. And already the psychosocial committee are doing a funded project on screening for psychosocial needs. So all that might sound very easy to accomplish, but let's consider some barriers to implementing or sustaining quality improvements designed in line with lung cancer OCPs or principles for best practice care. Firstly, Fragile et al., who are Australian researchers, found through their systematic review that accessing health services might include individual barriers involving cost difficulties, family responsibilities or transportation, and distance to a health service. And on the other hand, system barriers might include inflexible appointment scheduling, waiting times, poor continuity of care, poor communication within a health care team, and poor communication with a patient. And sequence and type of diagnostic investigations performed. Some patients require repeat investigations, and there's maybe insufficient tissue for nodal sampling or for biopsy, and they aren't able to be diagnosed at the by the time within the prescribed time limits. And private CTs may also need repeating. And the third barrier can be just the effectiveness and efficiency of the MDT itself. The purpose of the MDT may not be defined to its members. They might not really realise what is the purpose of this MDT. Is it education or is it treatment planning? There might be a lack of results available at presentation to enable treatment recommendation, and patients who are surgically treated might not be represented at the MDT, which might risk adjuvant treatments not being offered. So in conclusion, a sustainable MDT quality service improvement has the following features. A multidisciplinary team with strong leadership that develops a strategy to deliver best practice cancer care. Improvements are underpinned by the wider organisation's strategic plan and recognised by peak bodies such as Cancer Australia. And the MDT participates in data collection, monitoring and auditing to drive service improvement. And always remember that patient-centred care is always at the forefront of MDT quality improvement. And I'll just leave you with that little analogy as why quality improvement is worth the persistence and determination shown by MDTs. And I'd just like to acknowledge the members of the Pulmonary Malignancy Conference at Prince Charles Hospital, Cancer Australia's Lung Cancer Demonstration Project Team, Queensland Cancer Control Analysis Team, Metro North Hospital and Health Service, Clinical Operations Strategy Implementation Unit, and Metro North Primary Health Network, and Central Integrated Regional Cancer Service.
Thanks very much, Barbara. Microphone's on. So maybe stay and take lots of questions. So do people have questions for Barbara? Linda?
I think it's because they're recording it.
Sorry. I
just wanted to ask the data entry that the clinicians put in before the meeting. Is that in the cloud, or do they access it through Cerner, or how do they?
Oh, it is. Queensland Cancer Control Analysis team have their own server. It's not Cerner, and they have a platform called the Oncology Repository, Queensland Oncology Repository, and everything from the Queensland Health patient-admitted data, private and public, all radiation oncology from Royce, OSLAB, all the private pathology, all feed into that, and the cancer registry also feed in, the death registry and the cancer registry, and then it feeds out into the Queensland oncology analysis system, and then COOL feeds in and out of that. So all the data that they put into COOL, and they refer their patient via COOL, is then housed in a queue.
So is COOL in the cloud, or do they have access
web-based,
and they have a login to it?
Yes, and it's accessible all over the world. You can just log in anywhere. So I could be in England and be looking at my patients from there.
I told you they were doing well.
Yeah, it is an excellent.
I don't think you should tell our patients.
We don't all move to Queensland.
So when the fabulous technology came in, did you find it added much time to the meeting?
Oh no. And everyone uses it differently. Like I first started using it in 2006 when they had one module, and that was the lung cancer module. And then they've brought in so many more, so they have one for nearly everything, except for the very rare cancers. They have one for head and neck, but say if it's a neuroendocrine, they might not, because it's just not costing too much money. But they, so that's done all, and it's good because we have MDT coordinators, so they take that information and they use all that, and then we use it for research. So only the members of the MDT can actually access the MDT data, and there's a lot of checks and balances to make sure that there's no people inappropriately accessing as well.
Laura, I'm really impressed about your last slide with the reference to the total quality management. And I was wondering, have you modeled this on Atlanticare? I mean, they got an award because they basically use TQM to improve the health service. So is TQM kind of a vital ingredient in this organization, and is everybody subscribing to that?
Yeah. The what? Sorry.
The total quality management. You have the last slide with the starfish.
Yes.
I remember this is the Atlanticare and US use that as a model.
Yeah, I think so. And what they do in Queensland is the Queensland Cancer Control Analysis team also wear the safety and quality hat for Queensland for cancer. So they have a lot of subcommittees. They use all of their data to audit and review what's happening surgically, and they also so they do that and they do a lot of auditing and a lot of checks on what's happening in the cancer sphere.
Any questions? I'm not worried about running over time because we just reduced the panel time, so it's good and we've had a lot of conversation occurring now.
I was just interested in what you just said about being able to use the data for research, but then you said that the data is only available to the members of the MDT team.
Yes.
So what are the processes in place to allow the data to be used for research?
Yes. So as with any research, then you need your ethics approval. In Queensland we have another whole layer of ethics approval called the Public Health Act. So The data custodians is the manager of QCAT. When you do a research project, you can either request them to give you the data in identified or de-identified. You do have to have a public health approval, which is another layer, but it just follows basically the same ethical approach you do for accessing data. It's also because it's a viewing platform, so you can view pathology. If you're going to view pathology from Queensland Pathology, you still need to get the data custodian from Queensland Pathology. So it doesn't exclude you from making sure that you get all your proper data custodian approvals.
And you can actually access identifiable data in that way.
So if you're an MDT member, you can, and you just want to do it on your own patient cohort, all of it's identifiable. But if you're going, and I say I wanted to look at the Sunshine Coast data, that would be de-identified, and they would just give me the numbers. So, for example, I think one of our physicians wanted some smoking data and how many pack years, whether the patient had COPD and whether the patient had lung cancer and what type of lung cancer and their FEV values. And QCAT was able to pull all that data from 2009 for all of the Prince Charles Hospital patients and give him that breakdown, all de-identified.
I moved to Queensland.
And I actually requested that data, and we had it in 2 days.
Would the custodian sign off for everything?
Well, not if it's
Because that's internal.
Queensland Health and it's to do with his patients.
Yeah, that's
If
right.
it's
But if it's
proper
somebody else's
research, if it's
patients.
an audit,
Yeah.
yeah, different.
Sorry, so did you say that you started CRUEL in 2006? Is that when it started?
Yes.
Okay,
Yes.
and at that time it just had like a few templates though.
Yeah, so what happened was, I think they used to run a database there called CRUEL. So they got the idea and they used that data sheet that they were collecting on lung cancer and then pulled from those data elements. And then all through those years, it started off very basic, and now in the back you can click on to the staging. It's all like it can calculate smoking pack years, it can calculate the staging group. So you just put in your clinical staging and come up with stage 1B. And if you go into the back, it'll have a whole list of all of this different staging and the descriptors around it. So it's very, and it has psychosocial pages, clinical trial pages, everything.
And it lives in the clinical domain though. I think that's the key piece. It's not a research database outside of the clinical domain. It's a single source of truth within the clinical domain that can be used for research rather than the other way around. And I think that's a really
exactly
attractive
right.
thing to me. Yeah. Emily.
Oh, just a very simple question. How much does it cost and who pays for it and who runs it?
It's Queensland Cancer Control Analysis Team, and I think they're actually been in negotiations with Western Australia and Victoria to trial.
It is frustrating we don't
They use it, and they can use it for anywhere.
I just had a question on your data completeness. So, when you said there might not be any data for the TNM staging at the time of MDT, how do you take care of it, filling that up at the later stage? Is it comprehensive enough?
Yes. The rules in our terms of reference says that all results must be available at the meeting, but nobody follows rules. So we always go, well, the rules are meant to be broken. But anyway, for the majority of cases, yes, they all follow that criteria that all results must be presented, unless it's like a small cell and they've already started treatment, and or there's something they're not just quite too sure on, they want to ask them. But they're very comprehensive in their data collection. And then we have MDT coordinators that are nurses, and they actually go back after the meeting and they do a quality check of what was said at the meeting to what was put in the database, just a third check basically of what was checked at the meeting by the whole group. So,
would you find that true for all the tumour groups?
No, some are really excellent, and others they might have MDT coordinators or administration officers, and whilst they can learn and do it, they might not have the actual appreciation of why it's so necessary to be accurate. But it always depends on the leadership, who is the lead or the chair, or not. So Quanfong's not the chair, but he is a good leader. And that's the same with the Royal Brisbane. It used to be Dr. Robert Hodge, an ENT. He would chair it and he'd lead. No, so it all depends on who you've got running around.
Thank you. Thanks very much, Barbara. That's great.